name is Hina Akbarali. I'm a graduate student at University of Houston in the F&P program, and today we'll be talking about a specific kind of renal injury in this case study called acute tubular necrosis. The HP. When assessing the patient's medical history, three main aspects should be assessed. This includes present medical history, social history, and family history. In this case study, the patient has had hypertension for 25 years and congestive heart failure for 8 years. As we will see in the next slide, the patient is taking medications to maintain these illnesses from worsening, but his physical assessment and further evaluation of the patient may point to signs and symptoms of these illnesses. When asking about social history, it is important to assess the patient's occupational status. Doing so will help further evaluate the stress level of the patient. In this case, the patient is retired and lives at home with his wife, who was previously an accountant prior to retirement. Although the patient abstains from tobacco use, the use of cigarette smoking would be important to include. Typically, in a family history, you want to go back at least 3 generations, but this short family history tells us that both parents suffered from comorbidities. The father died of an acute myocardial infarction, and the mother died from type 2 diabetes mellitus. Now, the review of systems is very important. It essentially helps you paint the picture and further assists you in your diagnosis and clinical judgment. You would typically include the pertinent negatives and positives of subjective data. As you can see, the patient was so ill that the patient could not appropriately respond to questions, so the review of systems was not done. Now, what exactly is acute tubular necrosis? It's defined as tubule damage, and cell death that usually result from an acute ischemic or toxic event. There are 3 major causes of acute tubular necrosis: renal ischemia, sepsis, and nephrotoxins. For the sake of this case study, we will focus on renal ischemia. All causes of severe pre-renal disease, particularly if accompanied by hypotension, surgery, or sepsis, can cause post-ischemic, also called ischemic, ATN, or acute tubular necrosis. ATN is an unusual complication of heart failure. However, in this case study, the patient is seen with systemic hypotension and volume depletion. So what exactly is the plan? So after diagnosing the patient with ATN, he was administered renal dose of dopamine and furosemide IV. Despite the efforts of IV hydration of 1 liter of normal saline over an hour, the patient continued to have poor urine output and became fluid overloaded. This gave indication to place the patient on continuous veno-venous hemodiafiltration for 3 days. It is important to monitor the patient's intake and output after the CVVHD because the patient will have copious amounts of urine output. This device is typically it's basically like an external kidney device. Since your kidneys are failing, this device will help filter out any toxins, any function that the kidneys would do, this machine would be doing. Patient will continue his previous medications, that was digoxin, furosemide, enalapril, and famotidine. Now, the important thing to remember about enalapril is that ACE inhibitors in fact help protect the kidneys as well. So you'll even see patients with diabetes on ACE inhibitors, not only to control their blood pressures if they have it, but also to protect their kidneys. What are his goals and education upon discharge? So you want to limit his sodium intake to prevent any further fluid retention, because as you may have learned, where salt goes, water follows. So also be wary with salt substitutes because they are high in potassium. Also advise the patient to follow a low protein diet. Since we will be restarting the outpatient medications, it is important that the patient remains compliant to the medication regimen, since most of his medications affect his cardiac and renal function. These are a list of medications that can increase his risk of nephrotoxicity. So you want to educate the patient on avoiding these medications, especially the NSAIDs, since they are readily available over the counter, while the other medications have to be prescribed to the patient. Involve his wife in the plan of care to allow better adherence to his medication and his diet. If necessary, use a translator when providing discharge education to the patient and/or family. Continuity of care. So what parameters should be monitored by the patient once they are discharged? So you want to emphasize on the importance of monitoring his I's and O's, and educate the patient to notify the provider when he notices a trend in low urine output, which will typically be less than 30 cc's per hour. Now, the next thing you would also want the patient to monitor is his blood pressure. In a perfect world, I would like it if the patient checks his blood pressure twice a day, typically in the morning, and then again sometime in the middle of the day. But in reality, you will be lucky if they remember to check it even once throughout the entire day. So have the patient log the blood pressure readings and bring it to the next follow-up appointment. In a patient with renal disease, the goal blood pressure would be less than 130/80, but you also want to consider the patient's weight, height, and age. So when's the next time you would want to see this patient? Initially, I would want to see this patient 1 month after discharge to see if the patient has been compliant with his medications, his diet, and if he is meeting with his goals. In addition, I would like to get another follow-up on his labs to be sure he is not relapsing back into renal failure or CHF. You will notice that I have added an A1C to be checked due to his family history of type 2 diabetes, and he did spill out some glucose in his urine when he was admitted initially. The CBC will include the hemoglobin, the hematocrit, the BNP will include all of the electrolytes, and the UA I would prefer the UA to be a 24-hour sample. If you want to check for proteinuria, it's typically what is ideal for checking proteins in the urine is to do a 24-hour urine sample. And then I would have him come back 6 months later for another follow-up, and then after that still continue every 6 months just to see the patient's progression. And that concludes the case study for this presentation. Thank you so much for tuning in.